Section 1. Pneumonia. A simple guide for your NCLEX success. Pneumonia is an infection that makes the lungs inflamed. It specifically targets the tiny air sacs in our lungs, alveoli. These air sacs fill with fluid or pus. This makes breathing very difficult. It also reduces oxygen uptake. Symptoms range from mild illness to life-threatening emergency. As a future nurse prepping for NCLEX, you must understand this disease, how to recognize it, how to care for patients, how to prevent it. This guide will help you master essential concepts. We will break everything into simple, manageable pieces. Our goal: give you confidence to answer NCLEX questions correctly. We will start by defining pneumonia, then explore the types you will see in practice. The different phases of pneumonia, understanding the types. Pneumonia is categorized by where and how the infection was acquired. The most common type is community-acquired pneumonia, CAP. CAP germs differ from hospital germs. This distinction guides initial antibiotics. For NCLEX, CAP is most common in clinics and ERs. Another category is hospital-acquired pneumonia, HAP, developing after at least 48 hours in hospital. Hospital germs can be more resistant. Hospitalized patients are often more vulnerable. A subset of HAP is ventilator-associated pneumonia, VAP. VAP occurs after being on a ventilator for more than 48 hours. The tube lets germs enter the lungs. Aspiration pneumonia is another key type for the exam. It happens when food, drinks, vomit or saliva are inhaled into the lungs carrying bacteria that cause inflammation. High risk: stroke, decreased level of consciousness and neurologic disorders. Prevention measures are an NCLEX focus. Finally, atypical or walking pneumonia, often milder and caused by organisms like mycoplasma or viruses. Chest X-ray may look different and patients may lack high fever or a productive cough. Our bodies protect the lungs every day. Defense starts in the upper airway, nose and mouth. Nasal hairs filter larger particles. Air is warmed and humidified to reduce irritation. The epiglottis closes over the windpipe during swallowing to prevent aspiration. Next line of defense: the mucociliary escalator. Sticky mucus traps smaller particles, bacteria and viruses. Cilia sweep mucus upward like an escalator toward the throat. Debris is coughed out or swallowed, then destroyed by stomach acid, keeping lower airways sterile. If germs reach alveoli, alveolar macrophages, the deep lung security guards, engulf and destroy them. The immune system and antibodies recognize and neutralize specific pathogens. Protective reflexes like a strong cough clear irritants and secretions. Pneumonia occurs when defenses are weakened, overwhelmed by many germs, or a particularly aggressive germ is inhaled. Key triggers: weakened defenses, high pathogen load, high virulence. The development of pneumonia begins when lung defenses are breached and a person inhales tiny droplets, bacteria or viruses, from coughs or sneezes. Bacteria from the throat can travel downward, especially in the very ill or immunocompromised. Reaching the alveoli, germs multiply rapidly. The immune system recognizes the threat. An intense inflammatory response follows. Leukocytes, especially neutrophils, surge to the site. Capillaries become leaky. Fluid, red blood cells and proteins enter the alveoli. These mix into thick pus. The air sacs fill, a stage called consolidation, where lung tissue becomes dense. Alveoli lose gas exchange ability. Oxygen cannot pass easily into blood, causing hypoxemia. The body compensates with faster, harder breathing. Respiratory distress may develop as consolidation spreads. Patients may need supplemental oxygen. In severe cases, sepsis or acute respiratory failure can occur. This step-by-step process shows why early recognition and treatment are critical. Understanding who is most at risk is a key nursing responsibility and a frequent NCLEX topic. Major risks: infants under 2, adults over 65 and those with chronic lung disease, heart disease, diabetes, liver or kidney disease. Smoking and vaping damage cilia, hospitalization, immobility, recent surgery, anesthesia, all increase risk. HIV/AIDS, chemotherapy, steroids, transplant meds, dysphagia, feeding tubes, and ICU stays elevate risk. Recognize and act on risk factors to prevent pneumonia. Chest X-ray is the essential initial test. Infiltrates appear as white opacities. Bacterial pneumonia often shows elevated WBCs, neutrophilia, and hypoxemia on pulse oximetry. Collect sputum for gram stain and culture to target antibiotics effectively. In severe cases, obtain an ABG to guide oxygen therapy or ventilation needs. CT helps in complicated cases and detects abscesses or other complications. Common signs: sudden fever and chills. Cough may start dry, then become productive with yellow-green or rust-colored sputum. Dyspnea, tachypnea, and low oxygen saturations reflect impaired gas exchange. Sharp, stabbing pain that worsens with deep breaths or cough indicates pleural inflammation. Malaise and profound fatigue are common. On exam, crackles, overdense consolidation, breath sounds may be diminished or bronchial. Percussion over affected areas may be dull. In older adults, classic signs may be absent. New confusion, falls, or lethargy may be the only clues. Pleural effusion can worsen shortness of breath. Infected effusions form empyema, requiring drainage. Lung abscess is a localized pocket of pus within lung tissue. Sepsis and septic shock cause hypotension and organ dysfunction, a medical emergency. Recognize impending respiratory failure early to escalate care. Nursing care centers on supporting respiratory function, treating infection, and preventing complications. Start with ABCs. Monitor respiratory rate, work of breathing, and oxygen saturation. Ensure adequate oxygenation. Titrate devices to keep SpO2 above 92% or patient target. Start antibiotics promptly in bacterial pneumonia. Early therapy improves outcomes. Administer IV fluids for dehydration or hypotension and encourage oral fluids to thin secretions. Give antipyretics for fever and analgesics for pleuritic pain. Mobilize secretions, cough, deep breathe, and use incentive spirometry every 1 to 2 hours while awake. Sit upright to expand lungs. If unilateral disease, position with the good lung down. Suction if the patient cannot clear secretions. Educate. Finish antibiotics, rest, hydrate, get influenza and pneumococcal vaccines, and stop smoking. Escalate immediately when red flags appear. Mrs. Adams, 72, with COPD and diabetes, is brought by her daughter for fever, a bad cough, and 2 days of increased confusion. On assessment, temperature 101.5, heart rate 110, respiratory rate 28, SpO2 88% on room air, crackles in the right lower lobe. X-ray shows right lower lobe consolidation. CBC reveals leukocytosis. Community-acquired pneumonia. Priorities: oxygen to 2 liters improves SpO2 to 93%. Establish IV. Start fluids. Give first dose antibiotics. Collect sputum. Elevate head of bed. Monitor respiratory status. Encourage spirometry. Manage fever and watch for sepsis or respiratory failure. She slowly improves. Remember CAP versus HAP. Consider timing. Consider likely germs. Early antibiotics save lives in bacterial pneumonia. Older adults often present atypically. Confusion may be the main symptom. First priority, look for hypoxia. Monitor SpO2 and respiratory rate. Empyema requires drainage plus antibiotics. Use spit S. Support airway and oxygenation. P. Provide antibiotics promptly. I. Incentive spirometry and encourage coughing. T. Teach prevention, vaccines, smoking cessation, and warning signs.